and welcome to another insightful episode of MedSynapse Expert Series. I'm your host, Hetvi Shah, and today we're shedding light on a critical yet often misunderstood medical emergency, which is sepsis. Sepsis is a life-threatening condition that arises when the body's response to an infection causes injury to its own tissues and organs. Despite its severity, awareness about sepsis among general population remains low. And that is why this episode is so important. And joining us today is Dr. Dipanjan Hojai, a distinguished anesthesiologist and critical care specialist with qualifications including MBBS, DA, DNV, and DRNB in critical medicine. With a strong foundation in perioperative care and intensive medicine, Dr. Dipanjan will guide us through the early signs, risks, and preventive strategies around sepsis, empowering us all with the knowledge to act swiftly and wisely. So, welcome, Doctor, and it's such a pleasure to have you. And without any further delay, you can start your presentation.
Hi, Hedvi. Thank you so much for this opportunity to present this important topic. So, today I'll be talking about this important yet misunderstood topic in our medical field called sepsis. Uh, I suppose my target audience will include my fellow doctors, my juniors, paramedics, nurses, and also the general public. So I'll be giving a gist about this topic, since sepsis as a topic is huge, and itself we can write a 300 to 400 pages of book on it just single-handedly. So I'll not delve into deeper aspect of sepsis, but I'll give you a overview of what this is and what are the issues we're facing, and what are the understanding of sepsis in general population. So without any further delay, I'd like to go ahead. So what is the definition of this so-called sepsis? It's a life-threatening condition, and according to WHO, when the body's immune system has an extreme response to an infection, it which causes organ dysfunction, then we can term it as sepsis. So basically, in a layman term, as we know, if there is an infection in the body, we know there is an immune response against it. But when the immune response goes unmodulated, unmonitored, or gets into a anarchy mode, it also hampers our other vital systems, vital organs, and this which leads into our damaged tissues and organs, and it can lead into multiple organ failure. And sometimes, if it is not recognized early, or it's not even sometimes, it's many times actually, it's not recognized early, and if it's not treated promptly, it may lead to death, or even if not death, then prolonged morbidity and prolonged suffering, for even from patient relatives perspective, in financial constraint in admitting the patient into ICU for such a long time. So what does the epidemiology says about the sepsis? So this is an excerpt from taken from a very renowned journal published in Chest. So what is the burden of sepsis in India? It has been taken from 2017's data, and this shows that in India alone, approximately around 2.9 million deaths occur due to sepsis, and it is around 300 per 1 lakh population. As you can see, it's a huge burden in our society, and this data has been taken from the ICU admission itself. And many of the patient does not even reach to ICU or hospital setting; they even die in their home, and people often don't even understand why this has happened. In one of the studies, also in published in Chest Journal, is very reputed, revealed the 30-day mortality rate was 27.6% in ICU patient with sepsis versus the 0.5.3 in ICU patient with no sepsis. So as we can see till here, in ICU, one of the most important cause of mortality is actually sepsis, and it is often missed and often underdiagnosed. So in patient with sepsis, bacterial infection are most common, and with the majority being the gram-negative bacteria versus the gram-positive, which is more into the Western population. Followed by the fungal infection, which is picking up right now. Candida auris being a very notorious bug, which is creating havoc in our Indian ICUs with a mortality rate above 40% if not treated. Multi-drug resistant infection, in the other hand, comprising of 44 to 50% of patients with sepsis, and which creates a dilemma and issue with the antibiotic, which leads to more morbidity and mortality. So, what is the awareness level of sepsis in India? So, there was a survey done in 2021 where alarmingly, as you can see in the graph, in the answer of no, most of the people don't even know about what sepsis is, and the most alarming part is even in the healthcare profession, some even the 30 to 40% people didn't understand sepsis and its implication in our healthcare system. So, who are at risk? Basically, anyone can fall into this prey, although age of 65-year-old or very young patients do often poses high risk of sepsis, immunocompromised state, patient on long-term steroid or immunomodulators, like patient of rheumatoid arthritis on immunomodulator can also go into sepsis following infection. Patient with chronic uncontrolled conditions like uncontrolled diabetes mellitus and other conditions like liver diseases and kidney diseases also has a high propensity to develop sepsis prior after infection. Prolonged bedridden, post surgery, recent hospital admission, patient with long term invasive indwelling devices like your central line, which we use to give fluids, and the ICUs can also lead to a high risk of sepsis. Another pregnancy also poses a high risk of sepsis. So it's a complicated diagram where you can see for the pathophysiology of sepsis. As you can see, there are two components. You can see lipopolysaccharide and the lipoticoic acid, which is nothing but the components of the bacterial cell wall, differentiating between the gram-negative bacteria and the positive bacteria. So nothing, if there is an infection, there are immune response to it. There are CD14 14 plus toll-like receptors which get attached to that bacterial cell wall, which in fact does activation of further cytokine and other inflammatory reaction which gets reactivated, activated, and there is a cascade of different consequences such as sepsis, severe sepsis, and at last the septic shock. This is also complicated. I will try to make it a little simplified for the every viewers. So in a simple word, I would like to highlight something about MAP, which is mean arterial pressure. Mean arterial pressure is nothing but the product of cardiac output into systemic vascular resistance. In more layman language, MAP basically determines our perfusion of vital organs like kidney, liver, brain, lungs, etc., even intestines. So basically, what MAP does is there is a cutoff for MAP after which the auto-regulation of each organ fails. And if the MAP falls below that cutoff, the organ impairment starts and hypoxia and other sequelae and ultimately there will be multi-organ failure. So what does sepsis does? As I've discussed before, it increases production of nitric oxide. It is the hallmark of the sepsis pathogenesis, and we know that nitric oxide is a potent vasodilator. What does vasodilator does? It decreases preload and it decreases systemic vascular resistance. When there is a decrease in preload, there will be counterbalance by increasing the cardiac output to a certain extent to maintain MAP. Although at last, net effect will be decreasing in mean arterial pressure, and which will hamper the organ perfusion in general. Thus, the sepsis where organ dysfunction starts. So for general public, what are the warning signs? This excerpt has been taken directly from the NHS UK. So any adult or older child acting confused, slurred speech or not making sense, blue, gray, pale or blotchy skin, lips or tongue, on brown or black skin. This may be easier to see on the palms, on hands and soles of the feet. And unexplained rash, which doesn't fade away easily. And other organ dysfunction like difficulty in breathing, breathlessness, or breathing very fast can all be a warning sign that patient is going into sepsis, and hence we need to put him or put her into a urgent referral to a nearest emergency department or in ICU. Especially these all accompanied with high grade fever, and sometimes even hypothermia is seen. So even in absence of fever, there might be sepsis, which if often get masked and patient directly present to us with organ dysfunction. So what are the stages of sepsis? So there are three stages mainly. Stage one starts with the warning sign, as I have already spoken about. Abnormal fast breathing, high and body temperature. Both high body temperature and low body temperature can be seen in the earlier stages of sepsis and even in the later stage. Confusion, sweating, high heart rate are the other hallmark findings of the stage one. Stage two, when it's not treated or untreated, there will be certain changes in the mental state, further deterioration and breathing problems, decrease in the SpO2, and other abdominal or abnormal hurt can be seen in severe sepsis, where the mortality rate will and morbidity rate will increase. If the patient survives and still untreated, there will be the last stage, which is called the septic shock. Septic shock, where the BP is unable to maintain itself and will be needing vasopressors or certain medication to increase the heart rate or the cardiac output or the stroke volume, or increase the systemic vascular resistance called vasopressors, where it will try to increase the BP. Such state with sepsis is known as septic shock. So what do we do for diagnosis? And primarily what the physician does is there are some assessment tools which you can use. For example, one of the hallmark tools which we use is SOFA score, which is sequential organ assessment score. And in this, we will be saying in the different organ and the parameters are taken. For example, in the case of renal, creatinine is taken as a parameter. In case of CNS or the brain, Glasgow Coma score, which assess your consciousness level, are taken. Cardiovascular, hypotension or the BP is taken. Liver, bilirubin level is taken, and coagulation platelet count is taken. So following this, we give scoring and we assess the risk of possibility of mortality following the sepsis and septic shock. The other assessment tool are easier tools which are given by QSOFA, which is easier to be done and it can be done quickly, and we don't have to wait for any lab reports to come. So QSOFA is more preferred in emergency settings when there are no lab reports we have, and in emergency setting we do use QSOFA or SIRS criteria. In two or more, if it is present, then it's high risk of mortality in these patients. So interpretation, and if you give a score of 2 to 6, it's a moderate risk for mortality and warrants urgent admission. Score below 2 is low risk. Score 7 to 11 is high risk, and above 11 is very high risk of mortality with nearly 90 to 100% of mortality happening in this scoring level. Other scores include News, Muse, and Apache 2 scores, which can be used and can help further in our decision making. Other parameters like complete blood count, LFTs and RFTs, checking the organ dysfunction happening there or not, coagulation, imaging modalities like USG and lungs X-ray, chest X-ray should be done to exclude the source of the infection. ECG may be done. There might be arrhythmias precipitating after infection. And then there are biomarkers include the procalcitonin, CRP, total leukocyte count, and IL6, which may be used, which are more complex thinking. Although these biomarkers we do use initially, although we don't rely on them. We don't use procal to as such adjust antibiotic or start antibiotic if we have a high clinical suspicion uh, of infections in patient with sepsis. So, procal as a biomarker can also be used only for prognosticating. If you have started antibiotic for 14 days, if you need to stop, then maybe you can use procal and CRP. Otherwise, procal to start antibiotics only been used in cases of acute pancreatitis given by the PROCAP study, which was done before. And otherwise, the other important, very important blood report which should be done is cultures. Cultures can be taken from different areas. It can be taken from blood. It can be taken from the urine. It can be done from the sputum, which patient with cough coming with sputum can be done with cultures, and culture will guide us to be more specific. And although we don't wait for culture to start a broad spectrum antibiotics nowadays, we do start with the antibiotic, and after culture report comes after 3 to 4 days, we then de-escalate or escalate according to the sensitivity of the organism. Come to the management, it's a multidisciplinary approach. It comprises of emergency medicine physicians, critical care physicians, internal medicine, chest physician, plus minus surgeons. So, what does a critical care physician? What does it mean? So they are basically intensivist. They are specialists in diagnosing, treating, and managing critically ill patients, usually in the intensive care unit. We also handle life-threatening conditions, oversee complex treatment, and work collaboratively with other medical professionals to provide the comprehensive care. So it's a branch, and it's evolved into a super specialty field of medicine who had a postgraduate from anesthesia field or chest medicine or MNC medicine or internal medicine compete in an entry exam to get admitted in such courses. And these are the recognized courses which they do to get a degree in critical care medicine. So, critical care medicine, as such, is a multidisciplinary medicine, and it requires multidisciplinary approach with multiple teams working together for the betterment of the patient. And sepsis is one of the bread and butter for this branch, and patient exclusively are handled by this type of physicians. So we do have a few bundles or sepsis bundle. We call it sepsis bundle. This is nothing but guidelines which we follow to in treating sepsis or septic shock. So this is the latest one, which is given by the Surviving Sepsis Campaign Guideline 2021, and there are few recommendations which I'll not go into details, as most of the our everyone knows about it already. Although I would like to highlight some best practices regarding the recommendation which was given in 2021, and also there are changes from previous 2016 recommendations. And there's a newer 2023 recommendation on the SSC guideline, which has not much of changes. Although you all can go through it. It's given in the we can easily find in the Google. And I would like to highlight few like initial resuscitation and best practices. Patient with septic shock, they recommend that treatment should be started immediately and there should not be any delay. And regarding MAP of 65 equal or above of 65 initially is recommended, and over higher target MAP. Although MAP is variable, we can start with 65 and then we can have a target of more than 65 or more than 65 later according to the patient conditions and comorbid condition, etc. Regarding infection, the best practice they recommend continuously re-evaluation and searching for alternate diagnosis and discontinuing empirical antimicrobial if an alternative cause is established. As we know, the medication which we use, both the antimicrobial which we use in ICUs is more costlier than the conventional antimicrobial which you get in OPD basis, and also they poses harm to other organs such as kidney and liver. So we need to continuously reevaluate and continuously confirm that the patient has infection or not. If there is an alternate diagnosis established, well, good. well enough, we had to stop the empirical antibiotics, and we can de-escalate to a less costlier or a specific antibiotic macrobal for prophylaxis. Otherwise, there's no use of giving a high cost antibiotic microbial when it is not indicated. Other best practices for adults with possible sepsis without shock, they recommend rapid assessment of likelihood of infection versus non-infection causes of acute. As I said, we need to de-escalate the costly antibiotics, which also causes harm in our vital organs. Other best practices, patient with sepsis or septic shock at high risk of your gram-positive Staphylococcus aureus, which are methicillin resistant, they recommend using empirical antimicrobial with MRSA coverage at first go only. So it's a best practice. If we know that it's MRSA, or if we are suspecting it is MRSA, it's better to give an antibiotic with such coverage with and hit hard and hit fast. This is the basic rule of combating sepsis. And other parts for adult septic on sepsis and septic shock, they recommend optimizing dosing strategies of antimicrobial based on the PKBD and specific drug properties, so that we get the highest action, and so that we can hit the back with the microbes with precision and highest uh, highest uh, benefit. So for adults with sepsis or septic shock, they again I recommend rapidly identifying or excluding a specific anatomical diagnosis, so that a source control can be done. If there is a source, we need to refer to a surgeon. For example, the source might be a cellulitis in the leg. We need to drain it, and then we need to find out the source. We should be rapidly searching for the source. The sources sometimes are hidden, and we cannot find it in early stages. Although for when with nowadays with imaging and other modalities, we can do find sources and then control effectively. For adults with septic shock, then again they do recommend removal of intravascular access if there is a possibility of sepsis. Supposedly, if the patient has a intravascular access for long time, for let's say more than 7 days, and there's a new onset fever with multi-organ failure, we do need to change the intravascular access and put a new one. This is one of the best practices which has been recommended according to SSC. Others, basically, for long-term outcome and goals of care for adults with sepsis and septic shock, they recommend discussing goals of care and prognosis with patient regularly, which the patient relatives are already paying such a hefty fees in such ICU admission and prolonged length of stay. The patient party does have the right to know about the prognosis, daily care, and daily goals of care, which should be discussed thoroughly with patient and the patient families together. Other, for adults with septic shock, they recommend clinical team the opportunity to participate in shared decision making in post ICU and hospital discharge planning to ensure discharge plan are acceptable and feasible. Other, they also, the most important is sepsis and sepsis related treatment and common impairment and complication related to the treatment should be documented, and verbally should be made aware to the patient relatives during discharge, and hospital it should be included and should be documented in the hospital discharge summary. And at last, very important for survivors of sepsis and septic shock, is a huge psychological stress which we often ignore, and follow up for physical and cognitive to a recognized or eligible psychiatrist is very important, since the patient was staying in such a prolonged stay, and in ICU there are so many monitors, patient have could not uh, have a good time in that place, and which might lead to ICU psychosis, delirium, and depression at the later half, even after the discharge. So this is a very important aspect which should be explored more in the hospitals. So coming to the prevention, primarily prevention of sepsis, why it is needed? As we know, in India, we have got a very low cost settings in our ICU. In many of the cities, or even in the tier 2 and the tier 3 cities and the towns and villages, uh, we don't have access to high cost ICU or a standard ICU. So even the personnels are low. So if the prevention strategies can be implemented properly in the society, there will be reduction of burden into such low cost ICU. So what we can follow is patient can get the public can get vaccinated. So there are seasonal flu. The patient who are immunocompromised, who had recent splenectomy, can be vaccinated for the meningococcal or pseudomonal infections, etc. If the patient is prescribed, the patient should take antibiotics correctly. Correctly dosing should be done, and antibiotic abuse should be lowered down by healthcare professionals and also from the patients. If there are open wounds post surgery, care should be taken. Wash, Washing your hand and hygiene, maintaining hygiene is utmost importance. And this has been advocated by the Chest Journal, which I'm going to show you right now. So this is the direct excerpt from the Chess Journal, which they had done on India, where they had seen 652 patients in different ICUs, and they had also said, and which the first step to address the burden of sepsis in India would be to prioritize sepsis prevention, diagnosis, and treatment. So sepsis prevention is very important, and efforts to reduce nosocomial infection should be involved, and it should involve hand washing proper practices, proper contact isolation, use of appropriate personal protective equipment, and etc. And also following antibiotic stewardship and reducing antibiotic misuse. Lastly, coming to the chain of sepsis resuscitation, basically in sepsis, as we know, time saves lives. Time is very important in sepsis, and delay in treatment of sepsis would lead to increased morbidity and mortality, and hence there has to be a detection source control in a defined time. For example, culture should be taken when the patient comes into the ER. Culture should be taken within 1 hour, and after culture is taken, antibiotics should be started within 1 hour. And coming to the and simultaneously fluid resuscitation at 30 ml per kg to maintain a map of 65, above 65 or equal to 65 should be the target to maintain a map and lower down the shock index. So um, fluid resuscitation should be started as soon as possible. There should not be any delay, and further there should be further monitoring, and patients have need to be shifted to a ICU or a high dependency unit or a monitored unit as soon as possible, or less than 6 hours. And this has been, and if we follow such timeline, there is shown to be a decrease in mortality and morbidity rates for this patient, hence benefiting the patient coming with sepsis. At last, to summarize, to management of sepsis in a very easy way. So, what does sepsis contain? Sepsis contain a preceding infection. So, in one arm, infection control is utmost important. Antibiotic use and source removal is the hallmark of infection control. At the right time, you need to give the antibiotics. At the right time, you need to escalate the antibiotic. At the right time, you need to de-escalate the antibiotics. So these all clinical judgment and lab parameters which doctors do use and the specialist critical care physician use to manage sepsis. In the other arm, this modulation of host response, as we know, as I've said before, sepsis is basically overregulated or dysregulated host response to an infection. So it does by adding certain medications like steroid, hydrocortisone, vasopressin, blood purification techniques, APCs, thrombomodulin, which are into pipeline, which is not as given in the campaign yet. And and last term is hemodynamic management. Without that, the patient will die. So basically, if the patient goes into the third stage of the sepsis, which is called septic shock, hemodynamic management is utmost important. IV fluids, tweaking of IV fluids, checking for fluid responsiveness using PLR, VTI, and other like pulse pressure variation, stroke volume variation, and other static parameters like CVP also can be used to guide a IV fluid management for such patient in ICUs. Vasoactive agents also should be started at the right time after 1 liter to 1.5 liter of fluid. If the map is not maintaining, we need to start vasoactive agents like noradrenaline, which has been the drug of choice for many years since to increase the SVR and also for cardiac contractility. Others drug dopamine was included before. Right now, it is not that recommended. The first drug of choice is being noradrenaline. Thank you.
Thank you for sharing your insights on this crucial topic. And it was actually an eye-opening and informative presentation. And you have actually helped break down such a complex and life-threatening condition into something that everyone can understand easily. So thank you so much for sharing that. And to our viewers and listeners, if there's one takeaway from today, it is that early recognition and prompt treatment for sepsis can save lives. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay informed, stay vigilant, and spread the word.